Because migraine, many people with migraine have a myriad of symptoms, many symptoms, and it's trying to make sense of those symptoms. And the average length of history of patients to the headache clinic back home in Australia is 15 years. And you don't need to hear 15 years of history. If you know the information that's important, how to get it effectively, and then be able to reproduce the pain of the headache temporarily. It goes as soon as you take the thumb off the joint in the upper neck that you're examining. To be able to do that confirms cervical relevancy. And I've developed techniques which, used in a systematic way, can work out exactly which of the top 3 joints are involved. And there's no guesswork. You know exactly which joint the referred head pain is coming from. Headache and migraine is, next to back pain, one of the most common ailments known to humankind. So it is a real problem. And of course, the current management is virtually exclusively medication. To come in and be able to identify relevant neck disorders in the sensitisation of the brainstem is a really valuable thing to be able to do, because many people are destined to a life of medication unnecessarily. The most common mistake is that neck disorders do not play a role in the cause of migraine. And this is the belief, this is the perspective of the overriding medical model of headache. Right now, the medical model of headache dictates our perception, health professionals' perception of the migraine condition. And the medical model generally does not accept a causal role of disorders in the upper neck in the migraine process, the sensitised brainstem. I'm frustrated because elementary neuroanatomy tells us that upper cervical afferents have the potential or influence the brainstem. So noxious information, our understanding of pain sciences has come such a long way. We know that ongoing noxious information has the potential to sensitise the brainstem. Okay. I'm not the only one that's saying that. There is an international authority in Canada who uses anaesthetic blocks in the upper neck, and he would suggest that upwards of 80% of people coming to his clinic with a diagnosis of migraine, tension headache, in fact they're cervicogenic. They're as a result of disorders in the upper cervical spine. So upwards of 80%, and that's where my experience would suggest that 80–90% of people, yes, it's a significant, that's my clinical experience. Clinical experience just doesn't lie. So that's, as I say, that's my clinical experience. A headache or migraine that is unilateral, so it's one-sided. If sometimes that headache can be on the other side, so in other words, one episode may be on the right, the next episode they get is on the left, the next episode's on the left, the next episode's on the right. So this alternating behaviour tells us that there is a cervical reason for the headache, migraine. Or some people, their headaches actually alternate, swap sides within the same episode. For example, on day 1 it's on the right, day 2 it goes to the left, and day 3 it goes back to the right again, and day 4 it's gone. This alternating behaviour tells us without a doubt that we're dealing with the upper neck as the reason for the headache or migraine. Treatment does 2 things. We're dealing with 2 issues with everybody. There is a subtle disturbance in the C2-3 disc, a subtle disturbance, sometimes just an asymmetrical distribution of pressure, which then triggers muscle spasm, which then exerts pressure on one or more of the top 3 spinal joints. And if one of those joints is not rolling like it should, if it's stiff, then that can complain in the form of referred pain to the head. So we're dealing with 2 issues. We need to sort out what's happening at C2-3. And my hypothesis is we're dealing with a subtle disturbance of the C2-3 disc, which then triggers muscle spasm, which then pulls on one or more of the top 3 segments to refer pain into the head. 2 issues. Once you identify the segment that is being stressed by the muscle spasm, and that's easy to do, then by positioning the joints in a certain way, then the picture's complete. There's no guesswork. We're dealing with 2 issues. Deal with the issue at C2-3 and then identify the joint that muscle spasm is pulling on to create that head pain. Physiotherapy is highly regarded in Australia, and we've been lucky for a long, well, not lucky, we've earned it, but we are considered a very credible health profession. And we are, now I'm not sure here in Spain, but in Australia we are first contact practitioners, so we're not relying on referrals from doctors or anybody else. People can see us without a referral, and I think that just reflects the level or the regard that society has for physiotherapy in Australia.